Welcome to IMED Radiology's Advancements in Breast Imaging webinar. My name is Kate Sliver and I'm the Sales and Marketing Manager at IMED for New South Wales, ACT and WA. Thank you for joining us tonight for this event. October, as you know, is Breast Cancer Awareness Month and a timely opportunity for tonight's webinar, which will provide you with information on the latest techniques and technologies in the diagnosis of breast disease. During the month of October, and to further show our support to breast cancer awareness, IMED has been continuing support for breast cancer research with a $4 donation to breast cancer trials for every mammogram procedure during this month. Breast Cancer Trials is an independent group of 800 world-leading breast cancer researchers based in Australia and New Zealand who are committed to identifying treatments and prevention for people affected by breast cancer through clinical trials research. To date, Breast Cancer Trials have conducted over 83 clinical trials with over 15,000 participants. Before I hand over to our facilitator for the evening, Dr. Leon Tan, I do need to mention that this webinar will be recorded and you will have the ability to view it on our website. Additionally, if you select the resources button at the top of the page, you can download information on IMED Radiology's breast imaging resources. At the conclusion of the webinar, please make sure to stay online to complete your evaluation form for your RACGP points. As already mentioned, our facilitator for the evening is Dr. Leon Tan. Dr. Tan is a general practitioner with over 20 years' experience. He is currently working in family medicine at Glenmount Medical Clinic in Glen Waverley. In 2010, he completed a master's degree in wellness at RMIT and continues to consult in wellness and holistic medicine. He is a member of the Academy of Clinical Teachers at Melbourne University and is currently involved in both undergraduate and GP registrar education. I now will hand over to Dr. Tan to introduce our speakers for the evening.
Good evening, everyone. This is Dr. Leon Tan here. Just on behalf of IMED, thank you very much for allowing me to facilitate tonight's webinar, and I hope you find it very interesting, and I find this topic very interesting as well. Just a brief introduction to our speakers, and I'll talk about the format for tonight as well. Firstly, Dr. Manish Jian. Dr. Jian is a breast imaging specialist and clinical director at IMED Radiology, Monash in Victoria. Tonight he will be speaking about choosing the right modality when it comes to breast imaging. Ms. Corinne Uy. Ms. Uy is a breast surgeon from Southern Breast Oncology and Monash Health, and tonight she will be speaking to you about the assessment and early management of common breast presentations. The talk tonight will go for just under an hour, leaving time for questions at the end as well. And don't forget, with regards to the reinforcement activity for GPs, you will have to complete an evaluation form at the end. So just a reminder, the topic tonight is breast disease, of course, and the speakers will be talking jointly and talking about different aspects of breast disease symptoms, the latest updates with imaging and management principles. And I'll be fielding the questions as we go. Apologies if I don't get to your question. I'll try my best to get to questions as they come through with the discussion, particularly if they're relevant for the particular slides or topic that is being discussed. If you have more general questions, please save those to the end and we can address those perhaps towards the end of the talk. Without further ado, I'll introduce the speakers and get them started. So thank you, Manish, and thank you for Corinne.
Thank you very much, Leon and Corinne, for joining me and joining IMED tonight for this presentation, which is very dear to my heart. So as we all know, breast disease is not just breast cancer, it is a whole gamut of diseases. And we're very often asked, what do I do now? So let's have a look at what we can do. So we're trying to provide a basic overview of what is a correct test to order, when to refer, identify common breast signs and symptoms, and how to investigate a patient's problem and help them on their journey. So the learning outcomes that we're aiming to achieve is to identify common breast signs and symptoms and order and request age and risk appropriate imaging, how and when to refer to a surgeon, and provide basic management guidelines. I'm sure all of you are familiar with this one. Australia is one of the world leaders in breast screen imaging. So if you have an asymptomatic woman with population risk of breast cancer, between the ages of 50 to 74, they need to go to breast screen. However, we have this huge group of people who fall outside that, who are symptomatic. They may have a mass, lump, pain, nipple discharge, skin thickening, nodes or palpable masses in the axilla, or any other symptom. They need to go and have a diagnostic test. That's not appropriate to go to breast screen. Corinne?
Thank you, Manish, and thank you for inviting me to be part of this webinar. So I'm going to talk about triple assessment of a breast lump, which is something I'm sure everyone is very familiar with, and if you've heard it multiple times. Nevertheless, it is very essential to ensure that we maximize accurate diagnosis of a patient's symptom. The assessment of a breast symptom or triple test, if it's not concordant, then should lead to further investigations. So it comprises 3 components: the history, physical examination, asking the patients about their personal history, their family history, obviously their symptoms. Their imaging will include, usually to begin with, a mammogram and ultrasound. Certainly if they are young, and by young I mean under 35, often we'll begin with an ultrasound and include a mammogram following that if it's appropriate. And certainly MRI breast is now widely used and has certain indications which we may come to later on. The third component is pathology. So core biopsy is routinely used now because it provides more information about the diagnosis, but sometimes we do use fine needle aspiration. So a triple assessment is positive if any of these components is indeterminate, suspicious, or malignant. However, I think we should also note that there are some women who may not necessarily require all of these tests with their breast changes. And the other dimension, or the fourth component that sometimes as a breast surgeon that we also use, is looking at stability over time, which is also a very appropriate way to manage some of the women's symptoms.
Sorry.
So I thought I'd just mention nodularity because this is a very common presentation. Often women will come along feeling lumps in their breast or complaining their lumps or they're very lumpy in the breast. And I guess it's important to ascertain if there is a dominant lump amongst that nodularity. Breast nodularity is quite common and most pronounced in the upper outer quadrant. It also depends on the woman's menstrual cycle, how pronounced their nodularity would be. It's important to also consider the age of the patient. And thankfully, we have 2 breasts, so we can compare, is this a symmetrical nodularity or whether it's asymmetrical. So ultrasound is a simple test that we can use to confirm or refute a particular abnormality. And certainly most breast surgeons and myself, we have a bedside ultrasound in our office, in our rooms, and often we can actually show the patient in real time a particular lump that could be consistent with normal breast tissue and show it to them and compare it with the other side to give them some reassurance. And certainly if there is any concern, and certainly cytology or histology is recommended or required. And even in the presence of normal imaging, we have to consider doing a fine needle aspiration or core biopsy of a particular palpable lump that we're concerned about.
You might wonder why there's 2 people talking at the same time in a webinar. Breast imaging, like all of medicine, is a team sport. So in breast imaging, we work very closely with our team of surgeons, our referrers, our GPs, the patient themselves, sometimes the patient's family, and also pathology and other specialties. So let's start with the youngest patient we can think of, the adolescent or the young or the neonate. How do they present? The imaging guidelines we recommend are, in this age group, we always start with an ultrasound. However, if on imaging, the lesion appears to be malignant, then we have to work them up properly with a mammogram, with a proper core biopsy, sometimes with an MRI scan, or a contrast-enhanced mammography, or PET. We had a little audit. Sorry, Corinne.
You go ahead, Manish.
We had a little audit a little while ago, about 35 patients of young people under the age of 16 who had presented with breast symptoms to Southern Breast Oncology, and about 2/3 of them had presented with a lump. And the vast majority of these who had been seen by a surgeon had a discrete breast lesion. Most of the people who presented with pain had non-infected cysts, and they also had, some of them had nipple discharge, they had breast asymmetry, swelling, or skin rash. Corinne, any comments?
No, I think you've covered that. That's a very common presentation, a lump in the breast, and we'll talk about that a little bit more as we move along. That's fine.
So this is an ultrasound which demonstrates normal breast tissue in a young teenager. And remember, it looks almost identical in an older patient. So you can see the dense white and black tissue, which is completely normal. And this may present as a nodular mass. So when somebody comes to us with a palpable mass, we find this normal tissue. And very often we just say, no imaging abnormality, and send it back to you to evaluate further clinically. If you look at this lesion, it's a sharply circumscribed pencil-sharp margins of a lesion of which it measures about 20 millimeters in diameter. And in breast imaging, we always talk of O-clock position in the breast and how far the lesion is from the nipple. This is a hypoechoic ovoid lesion, which is sharply circumscribed. Look how close it is to the skin. So this is palpable. This is ultrasonically benign. So in a palpable lesion that looks like a fibroadenoma, Corinne, would you do anything?
I guess it depends on the age of the patient, and we also have to consider their family history, patient's anxiety. So again, I think triple assessment is important. So to begin with, if the patient is young, and this is clearly a fibroadenoma on clinical examination and has typical benign features, sometimes the simplest thing I would do would be a fine needle aspiration cytology. And our pathologists these days are very good in giving us concordant pathology results with a fine needle aspirate. And that is a simple test that we can do in our rooms, and it gives patients reassurance it's a fibroadenoma, and often these patients can be discharged after a very short follow-up. So, and sometimes older patients, core biopsy may be necessary to confirm the diagnosis, and particularly if they have family history as well. Occasionally we get surprises.
So this was a surprise. This was a young girl who was 13 who presented with a large, rapidly enlarging painful mass in the 6 o'clock position, right breast, 1 centimeter from the nipple. And note this is nearly 5 centimeters in diameter. It's got very sharp margins. It looks ultrasonically benign, but it was rapidly growing. She was very clear that this was not present about a year ago, and this had grown very rapidly. So this had a core biopsy and it came back as a juvenile fibroadenoma. They present very rapidly. They are large in presentation. I can't tell the difference between this and a Phyllodes tumor, so we send it back to the surgeons.
So juvenile fibrinomas is pretty uncommon. So we do see it in adolescents between the age of 10 and 18. And most often, because it's rapidly enlarging, they often lead to an excision. So sometimes if it's not too large, so under 4 centimeters, under 5 centimeters, occasionally we do manage them conservatively, but certainly if they continue to grow, then excision is appropriate. So we might come to a question which often a lot of patients are very concerned about, their fibroadenomas. And often their first question is, can this be a cancer, or can it increase my risk of cancer? Can it become a cancer? So fibroadenomas, I always reassure patients there are no increased risk of this becoming a cancer compared to the rest of the breast. So fibroadenomas contain normal breast tissue cells as the rest of your breast, and those breast tissue cells have the same chance of turning into a cancer, much the same risk as the rest of your breast tissue. So leaving a fibroadenoma does not increase the chance of developing breast cancer or developing breast cancer. And often patients are very reassured when they hear that. So often it boils down to their symptoms and to the size, age of the patient, and sometimes family history, whether we manage this conservatively or we excise it. Most of the time it's conservative management. Occasionally, if the fibrinomas are large or symptomatic, then an excision may be required.
So what do you do if somebody's got bilateral fibroadenomas or bilateral lesions?
So it depends if they are palpable and depends on the size. Often I think once we are happy with triple assessment or that it's consistent with a benign fibroadenoma, we may perform a short follow-up. And if they show no signs of growth and not causing any symptoms, then I think they can be discharged and back to their routine breast check as part of their normal health check. If they are within the screening age, have a normal screening, they do not require 6 monthly ultrasounds for the rest of their life, which I think is important to try and tell patients that these are benign. Often they are static, so once they don't show any signs of growth, then they are fine to leave as they are. And often patients will represent if a lump changes or becomes more obvious or becomes palpable.
Yes, the reason why I asked is we get a lot of patients who've got multiple small bilateral fibroadenomata, and we're asked to follow them up, and I hate following them up because it doesn't really add value to their management as far as I know. So would you agree?
Yeah, it causes a lot of anxiety and probably, money wasted as well for unnecessary scans. So as I said before, most fibrinomas need no treatment or follow-up. Majority will stay the same, and about only 5 or 10% may enlarge. And obviously we have to be wary, is this a giant fibrinoma or is this a phyllodes tumor? And certainly the ones that enlarge are the ones that we would recommend an excision. And if we can prove over a period of time, usually 6 to 12 months, that there is no change, then I think they can just have normal sort of breast check as part of the normal health check. They don't need ongoing ultrasounds.
This is another entity that is unique to young people. We call them adolescent cysts. Now, these are cysts that are formed in close proximity to the nipple areolar complex. So this young child is presented with a 14 millimeter hyperechoic or anechoic cystic lesion with good sound transmission in the 2 o'clock position, 1 centimeter from the nipple. There's the nipple there. So these are tiny little cysts right next to the nipple. And Corinne, do you want to talk about that?
Yeah, so adolescent cysts, as Manish mentioned, they're often found in the periareolar distribution, thought to be associated with the Montgomery glands. And this is different to the cysts that we see in the older women in their 40s and 50s that usually is a result of involutional change and hormonal change that are often scattered throughout their breasts. Often these adolescents will present with a lump that they can feel around their nipple areolar region, and often they can be tender or painful, mostly because of some inflammation. Very occasionally they can become infected. Usually they can be managed conservatively, but sometimes an aspiration is required to relieve their symptoms. And very occasionally if they have symptoms of infection, then a short course of oral antibiotics is required. These don't often tend to recur, so they don't need ongoing long-term follow-up. Once the initial cysts have resolved, it is unlikely that they will have another symptom. So these are probably the most common scenario that we see referred to a breast surgeon with in a young girl.
So gynecomastia is a very common entity seen in males. This is essentially the development of a breast bud or breast tissue in a male. Now, it's got a bimodal, or actually a trimodal distribution. First is in the neonatal age group, second is around puberty, and the third is in late adulthood. So on ultrasound, you can see just behind the nipple the presence of a breast bud, which has got a very characteristic location and appearance. So in adolescent, sorry, Corinne.
That's all right. So very, very occasionally we get referred gynecomastia in a young boy, though I don't see many of them. So presumably it means that the GPs are managing this very well, and they're aware that this is a common problem in young boys, and often due to hormonal imbalance, sometimes due to use of external steroids, and again, very rarely due to estrogen-producing tumors. Majority of these will resolve on its own accord, and often they can have very typical ultrasound appearance. So I would very rarely, if not never, recommend any sort of surgery to treat gynecomastia in a young man or young boy, because often it does resolve. However, in adults, we also sometimes referred gynecomastia, and these are due to, again, swelling of the breast tissue, and in an adult, it can be due to multiple reasons. A vast majority are idiopathic, though sometimes it can be due to certain medications, some health conditions, and very, very rarely, again, due to underlying cancer. So often when I see an adult with gynecomastia, it is routine to do a gamut of investigations in terms of their bloods, just to check their hormone levels and to check some tumor markers. More often than not, also to bear in mind that some medications can cause gynecomastia, so we look at this carefully, look at their alcohol consumption, because heavy alcohol use can lead to liver dysfunction, which can cause gynecomastia. And also, most of the time, more often than not, we don't find any cause for it. So majority of them are idiopathic. Often they have very typical ultrasound appearances. Sometimes we perform a biopsy if there's any concern, or they have other significant symptoms like discharge or a discrete lump. Male breast cancer is extremely uncommon. It accounts for less than 5% of all breast cancers, and often their symptoms are quite typical, and therefore it's easily recognized.
Question 1. Let's have a poll, please.
So the question is, which of the following is not true about gynecomastia, which is what we've just spoken about? Common condition in the male breast, always needing surgical treatment, sometimes requiring histological confirmation, and there is no association with the risk of cancer. So I'm pleased to see that majority have chosen always needing surgical treatment. So majority of these conditions are self-limiting. Surgical treatment really is reserved for men who have concerns about the look of the gynecomastia. Sometimes they present with pain as well, and pain can sometimes often be managed with medications, and the ones that we sometimes use is tamoxifen. At low dose can often improve painful gynecomastia. So surgery is often for men who are concerned about the cosmetic appearance of it. Certainly if there is an underlying cause for it, like medication, then the consideration is whether they can change their medications. But certainly it's, again, pretty uncommon to require surgical treatment, and often it's in young men who are very conscious about the appearance that may choose to have surgery. There is the option sometimes that liposuction can sometimes be performed by some plastic surgeons. It really depends on how much of it is fatty tissue and how much of it is sort of glandular tissue.
Just a question, Corinne.
Yes.
What tumour markers do you request in a teenager with gynecomastia?
So I have to say, in teenagers, I don't tend to do tumour markers. I tend to do it in the older gentlemen with unilateral gynecomastia. I think in the simple cause for gynecomastia in teenager, as I said, it's pretty rare cancer, looking at testicular cancer. So sometimes it involves examining their testes, and if there is no mass that you can feel, then I don't routinely order blood tests or tumor markers. So the tumor markers that I order in an adult would involve alpha-fetoprotein, a CEA, beta-HCG. So basically looking for underlying scrotal cancers or liver cancer.
Okay, so let's move on to a young 19-year-old girl which presented with a palpable lesion. Now, this ultrasound is actually very different to the ones that we showed before. So you can see it's got jagged margins. It's an irregular hypoechoic lesion in the left breast, which is 12 o'clock position, so right breast, 12 o'clock position, 3 centimeters on nipple. You can see these little white dots in the middle, which is probably calcium. So as we said before, if we think that it is malignant or it doesn't look like completely normal or benign, we have to work it up, and we did. So it's hard to see, but she's got a little spiculate mass here in the right breast, which you can see here with the arrow sign. And on the mag views and the cone compression views, you can definitely see a spiculate lesion in this young breast. So young people are not immune to cancer. They can get that as well. Corinne?
So the next question is really, what test do you order for a child or teenager for symptoms such as lump, discharge, pain? Is that a question for you, Manish?
Just start with an ultrasound.
Yeah, so there's no doubt, and as previously mentioned, you always start with an ultrasound for a young person. I think mammograms are probably not very useful for someone under the age of 30. If there's any concern, then certainly an MRI would be considered, but cancer in a child or teenager is extremely, extremely rare. Sort of, more than 1 in a million, I think.
In Australia, we get 7 women under the age of 25 every year.
Yeah, so I think certainly at Monash, we have had maybe 1 under the age of in your 20s, 1 every second year perhaps. So it's pretty rare, but something to consider and to be worked up appropriately. So what is the best test for solid breast lesion, and what's the commonest finding in the adolescent breast presenting with a lump?
So I'd say we'd start again with an ultrasound, because if it's an ultrasound in a young person, it's solid. And if it's solid, then we can go ahead and do a biopsy depending on what it looks like. If it looks benign, it's small, it's not clinically relevant, we can just reassure them and just maybe do at best 1 follow-up in imaging at all. But if it looks worrying, then we go ahead and pull out all the stops, get a proper surgical opinion, and do a biopsy. And to me, the commonest finding in an adolescent breast presenting with a lump is normal tissue.
Correct, and often I would also do a bedside ultrasound just to show the patient and show it's how it's symmetrical and it looks the same as the rest of their breast tissue, and often that's very reassuring.
Poll number 2, please. So the poll is, clinically the mass in an adolescent breast feels hard and tethered. What is a likely diagnosis? Normal tissue, cancer, or benign? Corinne, 40% of the audience says it's benign.
So did the rest say normal tissue then? So 35% said cancer, surprisingly, Manish.
Yeah.
I must say, I can't remember or heard of the last time an adolescent had a breast cancer.
Yeah, but if it's a mass that feels hard and tethered, it doesn't matter what age group, you have to consider cancer as first diagnosis.
Yes, so certainly that patient will end up with a core biopsy to confirm the diagnosis. particularly depending on the ultrasound findings.
So let's move on to a 20 to 35-year-old with a palpable mass with no family history. And the guideline suggests we start with an ultrasound. If it's benign or normal, we stop. And as we said before, if it feels or looks malignant, it needs the full workup. So let's look at some common conditions. So this is a 25-year-old girl who presents with thickened nipple and typical nipple eczema. So we landed up doing an ultrasound for her, and you can see the skin thickening and the increased vascularity on Doppler. And there was no mass behind the nipple. And she went back to the GP, who managed her with conservative eczema therapy and some emollients, and it resolved beautifully with no sequelae. This is another common problem in young lactating women. So there's a young woman, first-time mother, presenting with a red-hot, painful breast, and you can see the small hypoechoic fluid collection with debris within in the right breast 10 o'clock position, nipple margin, and is a typical abscess. So you can see that there, and our practice is that we get them to see the surgeon, and then we go ahead and aspirate them under ultrasound control, and we use a big fat needle under local anesthetic to aspirate the pus out, send it off for culture and cytology, culture and microscopy, and start them on antibiotics. So, Corinne?
Yeah, so breast infections generally fall into two groups. So certainly as the one as Manish has just showed, related to breastfeeding lactational mastitis. Often this is due to Staph aureus as the culprit, and often related to breast engorgement. The initial management involves emptying the breast, encouraging them to continue feeding, or whether it's expressing or feeding. And I think it's always very useful to involve lactational consultants. I would also, if they don't resolve with these simple measures, then often the next step is to consider oral antibiotics. And because it's nearly always Staph aureus, then simple flucloxacillin or erythromycin or Rulide will often cover Staph aureus. Another group of women that we see that are not breastfeeding that presents with mastitis, often they have a more mixed variable microbiology, which also sometimes includes anaerobes. It can be due to a combination of ectasia, periductal mastitis, which we commonly see in smokers, and a very rare condition called granulomatosis mastitis, which can be quite a difficult condition to treat. The initial management involves percutaneous drainage of an abscess or a collection, and sometimes they may require repeated aspiration. Often we do not like to do an open drainage unless they don't respond to repeated aspiration, or there is skin compromise, evidence of skin necrosis, or if they have quite significant sepsis. And I guess I've just put a point below as to beware the uncommon condition of presentation of inflammatory cancer. And often this is quite obvious because women do not respond to the antibiotics. They don't have the systemic symptoms that you get with infections, and often they are painless. So certainly if they don't respond to simple measures, then I think it's something to bear in mind and to consider a referral as well for further workup and imaging, etc.
Just a quick question, Corinne. Should we always do a breast ultrasound if presenting with nipple eczema?
Again, it depends on the age of the patient. Certainly if they are over the age of 40, again, it depends on if there's other associated mass or lumps that you can feel. I think that's probably the sort of simplest thing that GPs will often refer for to do an ultrasound, because sometimes you can't tell whether it's nipple eczema or whether it's Paget's disease. So certainly over the age of 40, they should have routine imaging if they haven't had one recently. But certainly if they are young, an ultrasound will be sufficient. And a trial, and if it's typical of an eczema type condition where it involves the areola, then a trial of emollients or moisturizers and steroids, often they respond within a week. If there are any further concerns, particularly considerations for Paget's, then they may require referral. So ultrasound may sometimes be used just as part of that workup due to the breast symptom.
So we talked about cyst before in a young child. So this is a palpable mass in a 32-year-old woman, no family history, which is presented with two cysts, which are completely anechoic, sharply circumscribed, fluid-filled bags of water. So, Corinne.
Yes, so do incidental tiny breast cysts require follow-up? I would certainly say no. Often these cysts are found because a woman has part of screening or they have pain, and often these cysts do not cause any symptoms. They're completely incidental. And if on the ultrasound they look like simple cysts, then they don't require any further follow-up.
Yes, I'm also wary about cysts that are 2 to 3 millimeters in diameter and are reported as complex or complicated cysts, because at that size, I would not worry about that. If it looks like a complex cyst or a cyst with debris at 3 to 4, 5 millimeters, I just ignore them. And it's only if they're bigger and they're causing symptoms like, let's say, a 30 millimeter cyst, then I would aspirate them and follow them up, perhaps, maybe. Let's have the next poll.
So which is true of breast cysts? They all require biopsy. They are hereditary. They may increase your risk of breast cancer, and they are commonest in the last years of reproductive life. And I think we've covered some of these.
Let's have a look at the results. Yep.
Yes. So that's very true. So they are commonest in the sort of in your 40s. They certainly have no, if there are simple cysts, there is no increased risk of malignancy. They are certainly not hereditary, and certainly I would not biopsy a simple cyst unless there's any concern on sonographic appearances. If there is thickened wall or a solid mass within the wall, then they may require a biopsy.
The only other time I've aspirated cysts is if they become symptomatic, if they've got hemorrhage within them and they're distorting the breast, or it's a huge cyst causing pain.
Yeah, so as we said before, breast cysts are very common, and often we see it in women in their 40s and 50s. Due to global involution, there might be multiple cysts. They can sometimes recur after aspiration. Ultrasound often confirms the diagnosis. I would send it off for cytology if there's any concern on the ultrasound, or if it's blood-stained, or if there's a residual lump requiring a core biopsy. So often cysts, when you aspirate them, they are greenish, brownish in color, and if there are simple cysts and the cyst disappears, then I just discard the fluid.
Okay, we might skip through this one. We've already gone through that point. So let's have the next poll.
So now we're moving on to high-risk family history. So just have a look at those various scenarios and which of the following constitutes a high-risk family history. So if grandmother with breast cancer, cousin with breast cancer in their 40s, aunt breast cancer in the 60s, and maternal grandmother with breast cancer in the 50s, an aunt with breast cancer in 40s, and mother with breast cancer in the 40s. So often we have a lot of patients who are very concerned about their family history of breast cancer. And often we can reassure them depending on their family pedigree and their history, how significant they are. So we'll see what the poll says.
And I guess also there's a difference in the risk if your mother was 80 or more when they had breast cancer. And very often we get people coming in and telling us that we were at a very high risk of breast cancer because my grandmother had breast cancer when she was 90.
Yes.
That doesn't really make a difference, does it?
Correct, yes.
Sorry, Corinne, just while people are doing the poll, what cyst size, if any, warrants an FNA?
So it depends on the symptoms. So if they're symptomatic and it's palpable, then it's something that I can drain from them at the wounds. If it's a simple cyst, regardless of size, if it's not causing any symptoms, then it can be left alone. And some patients will say they'd rather not have a needle in their breast, and it's safe to leave as it is.
Okay, the poll results are in, Corinne.
Yes, so essentially it depends on whether how close the relationship is. So usually we look at whether it's first or second degree relative, and we look at the age of when they had the cancer. So number 3, so aunt with breast cancer 42 and mother with breast cancer age 48, meaning you have one first and second degree relative with breast cancer under the age of 50. So that constitutes a high risk family history. So the first one, mainly because it's distant relatives and they're older, and same with the second one, those are sort of normal average population risk. So we'll talk about that next. So familial breast cancer only accounts for about 5 to 10% of breast cancers. Now, often with the younger the age, obviously, the more likely that you might see a familial breast cancer. Though in older population with breast cancer, we occasionally see a hereditary breast cancer. We'll just move to the next slide. So this is just looking at your family history and what constitutes a high-risk family history. So as I said before, so 3 or more first-degree relatives with breast cancer on the same side of the family, breast or ovarian cancer. If you have 2 or more first-degree relatives with these features, then they constitute a high-risk family. So breast and ovarian cancer in the same person, breast cancer in a young person under the age of 40, ovarian cancer before the age of 50, multiple breast cancer in an individual. If you get a male breast cancer, or if you are Jewish, Ashkenazi, ancestry, all these family histories sort of constitutes high-risk family history. So as we've shown previously, if they're more distant and they have it at a much older age, and if they're on 2 sides of paternal and maternal, then the risk is actually less. And I guess they also look at the size of the family. If you have 2 aunts with breast cancer, but there is a family of 10 women with only 2 having cancer, then that basically dilutes the risk. So that also actually is considered. So how do we manage a high-risk family history? So annual screening is recommended with usually 6 monthly clinical review. Now, if you were in the breast screen program and you actually fall into the high-risk family history, breast screen will offer you annual screening from the age of 40 to 60, then 2 yearly after that. So breast screen also collects information about your family history, and they will also produce a recommendation about the appropriate screening. So a lot of GPs, you'll be familiar that you might get letters from breast screen telling you what risk category your patient is in. Sometimes if they're in high risk category, they may also sometimes see a breast surgeon at the assessment clinic at breast screen, and they may be recommended screening outside the program if they have very dense breast tissue. So that's to consider as well. In general terms, when someone has a high-risk family history, we talk about prevention in the form of surgery, which is a prophylactic mastectomy. We talk about chemical or chemo prevention, and that's using tamoxifen to reduce their risk. And also environmental factors can play a part. So simple things like reducing alcohol, not being overweight, also play a part in reducing the risk.
Corinne, and just a quick question.
Yeah.
Oh, sorry. Just along the, with regards to BRCA gene and increased risk, there was a question about the role of screening men with the BRCA gene for breast cancer. Do we do that with mammography? Are they eligible for Medicare? What's the best approach for an asymptomatic man with the BRCA gene?
Normally, they do not undergo screening. They may have clinical reviews. I have to be honest and say I don't see many men with BRCA gene. So often it's the men who actually present with a breast cancer that may be diagnosed with a BRCA gene that obviously needs surveillance. It is very uncommon to find men actually having gene testing. So I don't think there is specific screening for men with a BRCA gene, but certainly they are encouraged to present if they have a symptom, because it would be fairly clinically obvious if they develop a lump.
Yeah, So we very rarely see men going through a screening program, and I don't think there are any recommendations anyway. So that brings us to the next teaching point, which is how often should we be screening breast MRI and doing screening breast MR in the detection of breast cancer in high-risk women? And the recommendation around the world at the moment is doing it once a year. Not any more than that. That doesn't seem to help. So let's talk about women who've got a strong family history. So the recommendation is that we screen them annually, as Corinne just said, and breast screen offers a service. If it's anybody I know, I recommend that we have digital breast tomosynthesis and ultrasound and MRI. If that's MR, particularly in the BRCA patients, to avoid radiation as far as possible. So that brings us to the next polling question, which is question 5. What is the most common presentation of breast cancer? Jared, let's get the poll up. What is the most common presentation of breast cancer? Breast lump, nipple changes, breast pain, skin changes.
While they're filling in the poll, Manesh, a couple of questions for you.
Sure.
Is MRI considered a superior imaging modality for inflammatory breast cancer?
Yes, it's got the highest negative predictive value of excluding breast cancer of all the imaging modalities that I can offer anyone. In that, the detection of a primary tumor that is causing the inflammation of the breast is best picked up on MR. Historically, we struggled with that with mammography and ultrasound, but certainly with MR, we're finding the primary tumor more often in inflammatory breast cancer.
And what's the role of contrast-enhanced mammograms? Where does that fit in?
Contrast-enhanced mammograms can be done anywhere that an MR is indicated, but at the moment it's reserved for people who can't go into MRI because we don't have biopsy capability with contrast mammography. And also there's consideration of radiation risk, because the radiation with the contrast mammography is a bit more than mammography, and MR is absolutely radiation free. On the flip side, contrast mammography is a bit cheaper than MRI, particularly if you are not Medicare eligible for getting a funded MR. So there's a significant cost differential.
So our poll results are for breast lump, which is true. So by far the most common presentation of breast cancer is breast lump, and it's actually in that order. But 80% breast lump, and then a smaller percentage nipple changes, breast pain, skin changes. But I think the GPs out there would agree the most common presentation of a breast problem that women come along with is breast pain. But obviously only a very small proportion of them will actually have underlying cancer. And it's pretty uncommon. About 10% of cancers are tender or painful. The vast majority are painless.
So if you get a 35-year-old woman with a palpable mass, we start with the mammogram or digital breast tomosynthesis and ultrasound, and MR or contrast mammography is reserved for where it's indicated. So let's look at a case. So there's a woman with a palpable mass, and I always ask the question, where is the mass? It's hard to tell on this mammogram, but on the tomo slice images, you can see the large spiculated lesion in the right breast laterally there. So it's in line of the nipple, and I put arrows there so I remember where the cancer lies. And on ultrasound, it's clear as day. You've got a spiculate mass in the right breast, 9 o'clock position, 4 centimeters from the nipple, which corresponds to the palpable abnormality. This is a cancer. Let's look at another case. So there's a little arrow sign there. You may not be able to see the lesion. So this is mammogram. You can see the spiculate lesion with a little bit of calcium there. And you can see there on the tomosynthesis, you can see the calcium and the spiculate lesion there. Now the screening mammogram. And on ultrasound, you can see the tiny little lesion in the left breast 4 o'clock position, 1 centimeter from the nipple, which corresponded to the mammographic abnormality, which underwent a core biopsy. Put a clip in and did a specimen mammogram to confirm that the lesion that we biopsied did indeed have calcium, and the clip corresponds to the mammographic abnormality. So in this sort of situation, the guidelines are very clear. Do a mammogram, do an ultrasound, but before the ultrasound, core biopsy or any core biopsy, I like to get my surgeon, friendly neighborhood surgeon, to have a look at the patient. And Corinne can tell us why.
Yes, a number of reasons. One, it's always important to assess the patient prior to biopsy, to review their clinical findings and to see if it's concordant with the imaging. Also, sometimes biopsy can lead to a bit of swelling, a bit of bruising, and it can make what could have been an impalpable lump palpable, or sometimes what you're feeling could be a small hematoma or a bruise, and it may actually affect your surgical planning. Secondly, I think it's also important that we have an opportunity to review imaging and also to work out what actually we want biopsy and whether they need the lymph nodes also biopsy depending on the appearance, and sometimes depending on which imaging centers they've been to, it may not actually be mentioned what their lymph nodes look like, so these need to be assessed as well. So I think it saves women having to go back and forth and allows us to actually examine them prior to biopsy to plan what is palpable, what needs to be imaged, what further workup is required, and also assist with future sort of surgical planning in terms of what the appearance of the breast looks like. So we would certainly appreciate if possible. I know patients are very anxious, but often if they're suspicious imaging or clinical findings, often we can see the patient fairly promptly so that there's no significant delay to go on to a biopsy.
Yes, the point I'm going to make is that always order the ultrasound with the mammogram, not one or the other separately, because it becomes very hard to interpret one in the absence of the other, particularly in the case of a symptomatic individual. So this is another important topic in this day and age, implant rupture. So the guidelines for implant rupture is if you suspect implant rupture in somebody who's got breast prosthesis, order an MR. The role of ultrasound in looking for implant rupture is very limited, and you order ultrasound only if looking for overlying palpable masses, nodes in the axilla, or periprosthetic fluid collections. So let's look at an MRI. So you can see that all the swirly bits that looks like a noodle in the middle, that's called a linguini sign after the pasta. So the capsule has ruptured. This is a normal implant on the left side. On the right side, there's an intracapsular rupture. And if you look at another sequence on MRI, you can see the difference in the texture of the implant. It looks heterogeneous on the right implant. The left implant is intact, nice and smooth, intact implant, overlying breast tissue normal. This is just a sagittal reconstruction of this right breast implant, and you can see the implant is coiled on itself, so it's a typical intracapsular rupture. Now, when the fluid which is contained in the implant leaks outside the host capsule, that's called an extracapsular rupture. So this is another individual with silicon leaking outside the host capsule forming a silicon granuloma. And you can see these lines within the implant where there's an intracapsular rupture. So to reiterate, the best test to assess implant integrity or rupture is MRI. And do implants increase your risk of breast cancer, Corinne?
I would say no. There is a very rare condition that we will talk about shortly, but in general, breast implants do not increase your risk of breast cancer.
So next polling question, please. My patient has allergan textured implants. She is worried about ALCL or the implant-associated lymphoma. What test should I do? Ultrasound, MRI, mammogram.
But ALCL is a very rare condition. I think it accounts for it's found in about 0.3% incidence in women who have had textured implants. But certainly they have gained quite a bit of publicity in the news and hence causing a lot of anxiety for women with implants.
So let's see what the polls say. The polls are correct. It is MRI. The difference between this MR and the one that we showed before is this time it does require contrast, because what we are looking for is the fluid collection around the implant, and the fluid collection has to demonstrate enhancement. So you can see the white line here, the thick white line on the left breast implant, and on the 3D MIP, you can see the enhancement or the whiteness of the implant. You can barely see the implant on the right side. So this is abnormal. This tells us that there's either inflammation or ALCL happening around the implant and the best way to find that is to aspirate that fluid and send it off for flow cytometry. So that brings us to the next teaching point. My patient needs MR but cannot have an MRI because they have a pacemaker, metal prosthesis, and we talked about that in that question that Leon, you kindly put through. What can we do? We can do a contrast mammo. Now, contrast mammo is basically a mammogram where you inject contrast. It's the same contrast that we use in CT. We inject it at a high rate, and we take rapidly pictures of both sides exactly the same way as we do for a standard mammogram. So the current indications are screening for breast cancer, for staging, in dense breast, and instead of breast MRI, where MRI is not possible. So let's look at a case. So this is an MRI, which throws it where I can show you a color map of a large tumor, and this shows you all that white stuff is cancer. The normal breast should look almost like that at the bottom of the image with the arrows, that it should be really dark and gray. All the white stuff is cancer. So white, and the rest of the breast parenchyma will look gray or black. And it's the same patient with ultrasound, where you can see the large spiculate lesion in the left breast, which turned out to be a large lobular cancer.
I just put this up because often patients are very anxious about things that can increase and things that they can do to reduce your risk. The most common, and often patients are very worried about what they have done to actually cause the breast cancer. And by far, I really tell them that unfortunately there are two things there is the two risk factors that we cannot alter that can increase your risk for breast cancer, which is increasing age, which none of us can control, and being female. There's obviously a whole host of other potential risk factors that are modifiable, and this includes things like potentially exercise that people talk about, being overweight or being obese. Alcohol consumption is something that has now come out to show that can increase your risk for breast cancer. Sugar is an interesting point because I don't think in itself increases your risk for breast cancer, but obviously there is a link to high sugar intake and being overweight. So certainly I encourage women to things that they can do to reduce their risk, such as exercise, not being overweight, particularly if they're most postmenopausal, and also to minimize alcohol consumption, which there is no actual rule about how much is appropriate, but I generally encourage no more than 2 or 3 standard drinks per week. So lastly, we just put this up just to remind you, if you had a 58-year-old lady who presents with a new lump in the breast, and she had a recent breast screen mammogram about 10 months ago, which was clear or normal, what would be your approach? So I think even though they had a normal breast screen 10 months ago, I think it's important for anyone over the age of 50 to have any new lump assessed appropriately and to go by the principles of triple assessment. So they should still have repeat imaging to assess their lump. So lastly, when should you refer? So certainly arranging appropriate imaging to begin with is appropriate. I think it's important to remember that breast radiology is an area of subspecialist expertise. So someone like Manish, who looks at breast radiology, mammogram, ultrasounds, MRIs every day and can provide a useful report is very important, because sometimes in places where they don't routinely do breast radiology, reports can be misleading and sometimes misleading for GPs. So it's important to identify who your imaging expert is in your area. And as I said before, it is nice to have the patients referred prior to a biopsy, and certainly we can arrange an MRI if necessary.
So in a nutshell, this is a single-page summary of what we were saying. If the patient's under 25, start with ultrasound. 25 to 35, start with ultrasound. If they are more than 35, always do a mammogram with an ultrasound, temporarily separating them or doing them at different dates. Makes it difficult for the radiologist to assess them together and to ascertain the relevance of each finding. And as Corinne said, if somebody's got very strong family history, we start screening 10 years before the index case, and personalized screening is on its way. See your friendly neighborhood surgeon, get them to assess the actual risk, and then they can have a tailored screening program. So if imaging is positive, then we pull out all the stops. We do biopsy, MRI, contrast mammography, PET scan, CT scanning, you name it. But under the age of 25, start with ultrasound. 25 to 35, start with ultrasound. Over 35, every time you refer, make sure you tick the box and say mammography with ultrasound in a symptomatic person. So thank you very much for attending, everyone. If there are any questions, please send them to Leon and he will pass them on to us. Is there any burning questions at the moment, Leon?
Yes, got a bit of a collection of some benign breast conditions for Corinne. So Corinne, just got a couple of questions for you. Firstly, papilloma in the breast. What is the management and surveillance of papillomas in the breast?
Yeah, so papillomas are usually, if you have a very good pathologist, often they will tell you that the papillomas are benign. In general, papillomas often lead to an excision because of the small risk of associated proliferative change. Sometimes in the older patient, particularly over the age of 70, with a very imaging and benign papilloma histology, sometimes I watch them. So majority in general require excision. Sometimes they can be watched. This is different to what we call a papillomatosis condition, where they've got multiple papillomas. And in that scenario, we know that there is a slight association with increased risk of breast cancer. So in women who have multiple papillomas, then we put them into a different sort of screening surveillance protocol.
Mm-hmm. Thanks, Corinne. And just a couple of questions about fibroadenomas. There's a couple of questions with some concerns with young women who present with the fibroadenomas or less suspicious imaging clinical examinations. So for a younger woman with a less suspicious imaging report, is it reasonable for a GP to refer directly for a core biopsy without having to refer to yourself?
What do you think, Manish?
I think
it's important to, first of all, work out if it is a palpable fibroadenoma, the age of the patient, because there are often fibroadenomas can be multiple, and I think it's not appropriate for someone to have multiple biopsies of what looks like typical fibroadenomas on ultrasound, and they are incidental and not palpable.
I agree with you, and I generally prefer that all my patients that I do biopsies on have seen a surgeon, purely because I don't want to be doing over-servicing the patient or trying to do invasive tests on people who don't actually need it. Because even though an ultrasound-guided biopsy or a clinically directed biopsy can be very safe, it's not indicated for everyone. So that's where I think we need to be sure that we actually do need a biopsy, and if we do need a biopsy, it does follow the proper channels and the proper pathway and assessment to mitigate the risk of not just complications, but also perhaps over-servicing.
Yeah, and as mentioned earlier on, not all patients require a biopsy, so sometimes, even though we talk about triple assessment, there are many patients who have very benign symptomatology, benign ultrasound that do not require a biopsy.
For those that have a clearly benign breast lesion that you are clinically satisfied is a fibroadenoma, is it reasonable to just have imaging surveillance? And if so, what's the period in between those? How often would you do that?
So generally, I would follow them up for 6 or 12 months. And if the fibrinomas have shown stability, then discharge them back to routine follow-up with their GP. And that's to say, GPs don't have to keep doing ultrasound, so they just have their normal imaging as part of their normal surveillance, depending on their age. And often I tell women that it's pretty obvious to them if the fibrinoma is going to increase in size, because what was not palpable suddenly becomes palpable. And that's when they can come back and see me. So that's the general recommendation.
Thanks, Corinne. Lots of questions coming in now, so I'm not sure how we're going for time. Apologies to those who we have unable to get to those questions. Just reading one here. How often should you screen a woman who has had a BI-RADS4 on previous mammogram?
So BI-RADS4, do you mean a BI-RADS4 lesion, which is a suspicious lesion on ultrasound?
Yeah, thinking that the indication is.
Yes, it's a BI-RADS4 lesion. If it's a BI-RADS4 lesion and it has already been biopsied, then we already know what the diagnosis is. So they should, if it's not a cancer, then it goes back to routine screening. If it turns out to be a cancer, then they would have annual surveillance.
Yeah, so it depends what the biopsy shows. If it's something that requires annual screening, we'll be referring to things with atypia, sometimes require annual screening. But if the biopsy is completely benign and we've proven it with histology, then they can just return to routine screening.
What monitoring do you suggest for a woman on MRT? Is a contrast mammography required after 5 years on MRT?
Do you mean HRT? Or?
I think that's what's implying, yep.
The hormone replacement therapy?
Yep, that's what I'm assuming the question's about, yep.
Yeah, so I think hormone replacement therapy, if they have no other risk factors, should have routine surveillance, 2-yearly screening. And depending on their breast density, sometimes there may be benefit from screening outside of breast screen program where they can access tomography with ultrasound, would be my only recommendation, provided they've got no other risk factors.
Okay. What is the recommended screening for women who have Ashkenazi Jew heritage but no known family history of breast cancer?
If there is no other family history, then routine screening.
If they're Ashkenazi Jewish, they do get annual screening irrespective of family history with MRI under the age of 50.
Do they, Manish?
Yep.
As a single risk factor?
Yes. So if they're Ashkenazi Jewish, they're eligible for MRI up to the age of 50, 1 per year, without any other additional risk factors or without any BRCA.
So when would you start the screening age?
They say 10 years before the index case, and if they don't have that, then we generally recommend at the age of 40, but not before.
Yeah, so presumably if there is no family history apart from being Ashkenazi Jew, would you recommend MRI screening between 40 and 50?
Yep.
So
but not before 40.
I'm not sure if that fits the rebatable criteria.
It does.
Okay.
This is quite a big question. Who do you recommend for BRCA gene testing?
That is a big question. So I think it depends on, first of all, if they have breast cancer themselves, a personal history of breast cancer at a young age. We also look at their type of cancer. So we know that there are certain breast cancers, such as triple negative cancers, medullary cancers, which have a high association with BRCA cancers. Just to mention also that in the last couple of years, the panel of testing for hereditary cancers have actually broadened. So apart from the BRCA cancers, they also have things like P10, PEL-B2, which also have been shown to be associated with breast cancer. So I think it really depends on family history. the age of the patient when they had cancer and their type of cancer. So often their breast surgeon or oncologists are usually very good at referring the appropriate patients for gene testing when necessary.
Thanks, Corinne. I know that's quite a large topic in itself. We have got a few further questions. I apologise to the audience. We are out of time. We will leave contact details. I know there's some questions about costs as well, Manish, which I'm sure they can direct to you guys at a later date, IMED, with regards to tailored screening and the cost of MR testing for breast cancers and things like that. So apologies, we're going to have to wrap it up there, guys. So thank you all for your attention. And I'd like to thank Manish and Corinne for a fantastic talk, covering quite a lot of topics there, but really focused well on the clinical and imaging aspects for us GPs to get a practical handle on what to do with these patients. So thank you very much.
Thank you, Leon.
Thank you.
Corinne.
And you'll be redirected shortly to your evaluation of the presentation. Thank you.